talk about the anatomy and embryology of the venous system. I'm going to try to make this interesting and throw in a number of comments that are of relevance to clinical situations. That first slide is obviously the Grand Canyon in my home state of Arizona. That's about a 5,000-foot drop and 11-mile descent down into the canyon. So anatomy and embryology. That's my disclosure slide. That's a place up in northern Arizona called Pariah Canyon, another spectacular place. So start with embryology of the venous system. It is bilateral early on, but then the left side regresses. The right side becomes the IVC and the SVC, and the anterior cardinal veins become the cranial veins. The posterior cardinal veins are now replaced by supracardinal and subcardinal veins. The supracardinal veins become the veins in the cranial abdomen, and the subcardinal veins become the veins in the caudal abdomen. The posterior cardinal veins becoming caudal veins, caudal abdominal veins. Most of them regress. They do become the common iliac, internal and external iliac, the azygos, and the hemiazygos veins. The IVC does come from bilateral veins, but the left side regresses most of the time, but there are a number of variations that can occur. So you can have a completely absent IVC, and you can have a duplicated IVC. If there's a completely absent IVC, sometimes you'll see the azygos and or the hemiazygos take over as the drainage from the lower extremity. The veins in the lower extremity start with the capillary networks and become marginal sinuses, and then into the deep and superficial veins. That's a place called Chiricahua National Monument down in southeast Arizona. That's a hike called Heart of Rocks. It's truly spectacular. Okay, a little bit of histology. The venous wall has intima, obviously. It's a single layer of endothelial cells. The internal elastic lamina, this thick layer of elastic fibers, frequently missing in smaller veins. The venous valves are bicuspid, and they're at the base, and there's turbulent flow within the sinuses of these valves, and that's actually what initiates closure of the valve. It's not attempted backward flow, it is turbulent flow in the sinus. Good morning. Turbulent flow in the sinuses that initiate closure of the valve. And there's a medium that smooth muscle and collagen. Great saphenous vein and small saphenous veins have more smooth muscle, and they are contractile and really resistant to become varicose. If you think is a great saphenous vein that is very tortuous, that may well not be the great saphenous vein. The tributaries have thinner media, so they can become varicose. And the deep veins have as much smooth muscle, but more collagen, so they're more rigid. And the larger the vein, the less smooth muscle there is. And finally, the adventitia is a loose connective tissue. The importance of this adventitia is that this is where the lymphatics, the vasa vasorum, and the nerve fibers occur. So if you are trying to access a vein, one of the best things to do is to go all the way down to adventitia and inject local anesthetic, being careful not to compromise the lumen of the vein so you can't get in, but it'll make for a completely anesthetic insertion of the sheath and the needle, so it's nice to be able to do that. Lymphatics, I think, produced lymphedema with my tumescent anesthesia in some patients because I've probably destroyed some important lymphatics within that adventitia. And it's rare, but I'm convinced I've actually done that in the past. And then the great saphenous vein, as we know, is invested in fascia, so it's even less likely to develop dilation. That's true also of the small saphenous vein. So a bit about terminology. So agenesis means complete absence of a vein or a vein segment. Aplasia indicates the lack of development of that vein or vein segment. The vein is present, but it's quite small in size, and its structure is similar to that in the embryo. Hypoplasia indicates the incomplete development of the vein or a segment of vein. It's less severe in degree than aplasia, and the hypoplastic vein has a reduced caliber with a normal structure. Now, here's a nice ultrasound image of a tributary, which is functioning as the great saphenous vein because the great saphenous vein itself is quite hypoplastic. Dysplasia indicates a complex abnormality of the development of the vein. Atrophy indicates a decrease in the size or a wasting away of the normal vein. And a venous aneurysm indicates a localized dilation of venous segment with a caliber increase to 50% compared to normal. This is a bit controversial because this definition essentially has been taken from our arterial side, and it may not be completely accurate, but at least that's what we have to work with at the present time. And venomegalia designates diffuse dilation of one or more veins with a caliber increase, again, 50% compared to the normal. Proximal, this seems kind of basic, but proximal indicates closer to the heart and distal indicates further away from the heart. So when you read the literature, you should adhere to those definitions. Veins have tributaries, not branches. Arteries have branches, but the veins have tributaries because of the direction of flow. Now, a bit about the saphenofemoral junction and the sapheno-popliteal junction. From a strict anatomic sense, the junction would be right exactly where the saphenous vein enters the deep system. However, that's been expanded to a certain extent to include everything. And you can see in this image down below, includes from the preterminal valve in the saphenous vein all the way up to the suprasaphenous vein valve in the deep system. That's just a description of what I said. Also, veins have confluences. They're not. There's not a bifurcation. They actually, because again, the direction of flow, they are confluences. And there are duplicated segments. One of the most common is a duplicated femoral vein. Typically, you'll see a smaller caliber vein and a larger caliber vein if it is truly duplicated, or if there's a duplicated segment. If you have a patient that develops a DVT, perhaps after one of your treatments, almost always it'll be in that smaller segment rather than the larger segment. That's also in northern Arizona, Antelope Canyon. So a brief overview of the head and neck and upper extremity, and then we'll get into the abdominal and lower thoracics. So this is a head and neck, and I'll go through this in a brief detail. Starts at the hand with the palmar venous arches, and the digital veins becomes the basilic and ulnar, and the radial and cephalic, on up to the basilic on the medial aspect of the arm, brachial in the mid portion, and cephalic in the outer portion. These coalesce to become the axillary vein, and finally into the subclavian vein. With respect to the lymphatics, it's important to know that the collecting ducts, the thoracic duct, collects from the lower body, abdomen, left upper limb, and the left side of the thorax, head and neck, while the right lymphatic duct collects from the right side of the head and neck, right upper extremity, and the right thorax. The right lymphatic duct is formed by the union of the right jugular, the subclavian, and the bronchomediastinal trunks, and it ends entering into the thoracic duct. It's at the roof of the neck, drains from the lower limbs, pelvic cavity, and lower extremities. Now, we know about the thoracic outlet syndrome. There are three main types: the neurogenic, the venous, and the arterial. The neurogenic is the most common and presents with pain, weakness, and occasional loss of the muscle at the base of the thumb. The venous type results in swelling, pain, rubor, cyanosis of the arm, and occasionally presents with a upper extremity DVT, like in a Paget-Schroeder's syndrome. And the arterial type has pain, coldness, and pallor. The thoracic outlet syndrome may result from trauma, repetitive arm movements like overhead, like a carpenter or pitcher, tumors, pregnancies, and a cervical rib. The diagnosis is supported by nerve conduction studies. If it is neurogenic, it affects about 1% of the population, more commonly in women, and occurs mostly between 20 and 50 years of age. Treatment is exercise to strengthen and improve the posture and sensation, if they can, sensation of the overhead repetitive movement. But if that's your job, it's hard to do. Surgery is reserved for significant symptoms that may include intravascular stenting, rib resection, and or scalenotomy. If it's associated with a DVT, as in the Paget-Schroeder's, anticoagulation, thrombectomy, stenting, and rib resection are all options, and very commonly all of them are used. That's up in northern Arizona. That's Humphreys Peak. That's the highest point. It's 12,600 feet. That's a nice hike to do in the summertime, and it's a ski area in the winter. With respect to the physiology, it's interesting to think of these four compartments of drainage: the superficial venous compartment, the saphenous compartment, the perforators, and the deep venous compartment. Deep muscular and axial veins drain the muscles and the muscular sinuses. Perforator veins connect the superficial to the deep veins through that deep fascia. And communicating veins connect veins within the same compartment. An example of that is the vein of Giacomini connecting the small saphenous vein to the great saphenous vein, or an intersaphenous vein in the calf, which is important because if you have somebody who has great saphenous reflux along the length of the vein, and then has small saphenous reflux beginning in the mid portion of that small saphenous vein, because the reflux is coming through that intersaphenous vein. If you treat the great saphenous vein and the intersaphenous vein and close those, very often that small saphenous vein will resolve without having to be treated separately. The intermuscular compartments include the femoral vein in the thigh, the deep femoral vein, the popliteal, both the anterior and posterior tibials, and the perineals. Those tibial veins are very common sites for post-treatment DVT, especially following foam sclerotherapy. And then we have the intramuscular compartment with the gastrocnemius and the soleal muscles. In the thigh, you can see the common femoral vein and the deep femoral vein. And then the femoral vein, we used to call that the superficial femoral vein, but there was so much confusion thinking it was a superficial vein. And in fact, it's deep, so they've dropped the superficial vein. It is now superficial femoral vein. It's now the femoral vein. And then the popliteal vein, great and small saphenous veins. Sciatic vein is a vein that should have regressed, but sometimes it remains. And if it's involved with reflux or varicosities, it can produce pain very similar to sciatica, although it's usually pressure related. And then at the knee, there's the popliteal vein. And down in the leg, in the deep veins, there's the muscular veins, the soleal and gastrocnemius veins. Gastrocnemius veins on top, the soleal muscles, soleal veins on beneath. And you can see on the diagram on the right, starts with the dorsal arch, posterior to anterior tibials and the perineals, small saphenous, great saphenous, perforator veins in the calf and thigh, the femoral vein, and then finally up to the external iliac vein. The anterior, posterior, and perineal veins are important in the calf because those are where you'll get the DVTs either spontaneously or post-treatment. And the foot veins have medial and lateral plantar veins, and I'll talk about that in a few minutes. That is a summer thunderstorm up in the Grand Canyon. So superficial veins in the lower extremity in the thigh or leg. There's some confusion in the literature. A lot of the internationals refer to the leg as the lower portion of the leg, and thigh as the upper portion. Again, there are the great and small saphenous veins. It's no longer the long or short or greater or lesser. It is now the great and small, to avoid confusion with shortening them. They do course outside the deep muscular fascia, which is important because they're much more likely to become incompetent than are the deep veins. And they drain the skin and the subcutaneous tissue. The anatomy of the superficial system is quite variable, and it's necessary to understand these variabilities to properly evaluate and diagnose, to make sure you treat the appropriate veins. So from above downward, the great saphenous vein up to the saphenofemoral junction, there's a pre-terminal and a terminal valve. Some of the tributaries include the external pudendal, the superficial circumflex iliac, and the superficial epigastric. That superficial epigastric is important, we think, to preserve flow through the proximal great saphenous vein after a endovenous ablation procedure. There's some controversy about that, because some Europeans are now ablating all the way to the saphenofemoral junction and not preserving that flow through the superficial epigastric, and they're claiming good results. And then the anterior accessory, posterior accessory, and superficial accessory of the great saphenous vein are also important, particularly in the case of recurrence. This is the anterior accessory is a very important source for recurrence after endovenous ablations, not so much after surgical ablation. The small saphenous vein with a sapheno-popliteal junction. Also, there's a terminal and a pre-terminal valve. There's a cranial extension of the small saphenous vein, which is very common. If it joins the great saphenous vein, it'll be called the vein of Giacomini. If it courses up and joins through a perforator in the thigh or up into the buttocks and into the pelvis, that's called a cranial extension or a thigh extension. The posterior and anterior thigh circumflex veins are also important sources of reflux. And the intersaphenous vein, I talked a little bit about that earlier. The lateral venous system is important for those women who have varicosities, small telangiectatic or reticular varicosities on the lateral aspect of the thigh. And then in the foot, there's the dorsal venous network and the dorsal venous arch of the foot. And then that lateral marginal vein, that's supposed to regress, but that's important in things like Klippel-Trenaunay syndrome. That may be one of the major outflow tracts in those patients. And the foot veins, the plantar and dorsal venous arches, and the deep veins, the dorsal venous arch, if it's medial, it'll become the great saphenous vein, and the ones on the lateral aspect will become the small saphenous vein. Within the saphenous compartment, there is the great saphenous vein. There's an anterior accessory saphenous vein, and you can tell the difference between the two because it'll be the great saphenous vein. The anterior accessory will be in alignment with the femoral vein, and so you can tell which one is which. And then there's that posterior accessory saphenous vein. The small saphenous vein, it's an image here, the small saphenous vein coming into the popliteal vein. That is an abnormal vein of Giacomini, so an extension of the small saphenous vein, which will join the great saphenous vein. And then there's a thigh extension or the vein of Giacomini. That's it, a transverse ultrasound image deep within the thigh and within the fascia. So that's the image of the great saphenous vein joining the common femoral vein and that superficial epigastric. Most of us start our thermal ablation below this site, but again, some of the European literature indicates very good success with ablating all the way to the saphenofemoral junction. This will probably avoid those recurrences through the anterior accessory saphenous vein. And the great saphenous vein is within the fascial compartment. It's a very well-defined layer. It's called the saphenous eye, and the tributaries pierce the layer of the fascia to reach the great saphenous vein. There's an example of it, an ultrasound image showing the tributary coming down through the fascia here and going to become or join the great saphenous vein. Lots of variability. About 70% of patients have one of these three variations. It could be entirely great saphenous vein all the way
Okay.
along.
No worries. Yep. Bye-bye. Bye-bye.
It might split, join with a confluence in these areas. It might also be hypoplastic.
It's muted now.
Come here. Here.
So
What's wrong with Lucy? What's wrong?
Dr. Mathai, can you please mute your Dr. Mathai, can you please mute yourself?
Thank you. Thank you. I'm trying to.
there we go. 30% of the patients will not have the complete great saphenous vein. They'll exit to a tributary, which will function as the great saphenous vein someplace along the course. The great saphenous vein can be completely aplastic, as in this image. This is what's functioning as the great saphenous vein. There's nothing in the saphenous compartment. That same image with the great saphenous vein functioning as a great saphenous vein and a small, very hyperplastic great saphenous vein. If it's absent, you have to think that the patient probably had some sort of treatment in the past. And again, that image of the saphenous, the tributary coming down and then joining, so that it becomes the functioning great saphenous vein. And in this image, there's actually a hypoplastic great saphenous vein along with it. Sometimes it's difficult to identify the great saphenous vein in the calf. If you can identify the tibia and the mediogastrocnemius vein, known as the tibiogastroc angle sign. Here's the tibia and here's the gastrocnemius muscle, and in the angle between is the great saphenous vein. That's a pretty good clue when you're trying to find it in the calf. In the accessory great saphenous vein, anterior and posterior accessory saphenous veins, it's sometimes a little bit confusing because the posterior accessory great saphenous vein is also in the calf, formerly known as the posterior arch vein or Leonardo's vein. And then the posterior accessory saphenous vein in the thigh, that's it again, within the saphenous compartment, above the muscle but below the superficial fascia. And that is the proximal venous Giacomini that comes up from the small saphenous vein. There are some medial and lateral tributaries. As I said, these anterior and posterior accessory veins, that proximal venous Giacomini or thigh extension. So from the abdominal wall and pudendal areas, those three, the important ones are the superficial circumflex, superficial epigastric, and superficial external pudendals. Those all drain into the great saphenous vein, usually below the terminal valve. So if you have a competent terminal valve, so competent sapheno-popliteal junction, these can drain from the pelvis and render the great saphenous vein distal to the terminal valve incompetent. And that's a very common presentation. So any of those three veins can transmit retrograde flow out of the pelvis and can be render that great saphenous vein incompetent distal to the sapheno-femoral junction. So again, if what you think is a saphenous vein is tortuous, that may not be the true saphenous vein. Again, there's that image of this very hypoplastic vein. If you're going to ablate the great saphenous vein, the true great saphenous vein is probably going to be competent. If you're going to ablate the more proximal one, you can come through this tributary and it'll join, and it's usually relatively easy to get through. It's really important to know where the terminal valve and the subterminal valves are, because again, the entrance of the superficial epigastric and those circumflex, that's where they come, pudendals. So if this is competent, they come from the pelvis and then render this portion of the great saphenous vein incompetent. Saphenous nerve is right along the vein. It's especially the lower in the leg that you go, the closer this is down in the calf. It gets closer to the vein, and it can be injured in a thermal ablation. So caution is advised when you're ablating a great saphenous vein, especially further down in the leg. That's down in southeast Arizona, called Cochise Stronghold. So just about the nomenclature of the superficial system, we have the small saphenous vein, again, not the lesser or the short. There's a sapheno-popliteal junction, the cranial extension of the small, which can be the vein of Giacomini, again, if it enters the great saphenous vein. That intersaphenous vein, and the importance of that is reflux from the great into the small. Sural nerve is, with respect to the small saphenous vein, it's very close to the vein, the further in the leg that you go. I have had a case of not being able to thermally ablate a small saphenous vein because the nerve was actually within the wall of the vein, and embryologically they come from the same place, so it just didn't separate at all, and I simply couldn't do. Every time I'd turn on the generator, the patient would still have pain in spite of very adequate tumescent anesthesia. 10% of CVI patients have small saphenous involvement only. The terminal valve is variable. About 75% of the time, it'll join the popliteal vein or the femoral vein somewhere near the popliteal fossa, but 25% of the time it terminates in the deep or superficial system cephalad to the popliteal, as in this one. Common perineal and posterior tibial nerves are very close up to, near the cephalad portion of the small saphenous vein. That's important when you're doing a thermal ablation procedure to avoid injury to one of those nerves. Because if you produce a motor dysfunction, that's going to either be painfully foot drop, and that's a real problem. Deep system via cranial extensions. Normal flow pattern is from the popliteal fossa cephalad. That's that same image. Abnormal venous Giacomini, incompetent, small saphenous vein comes into the popliteal junction. The small saphenous vein also enters sometimes the gastrocnemius vein and then into the popliteal vein. Let's see, there's a video image. That's small saphenous down into the gastroc and then down into the popliteal vein. And the small saphenous vein, again, from the distal calf to the SPJ, it rests on the top of the gastrocnemius muscles, so that you can see that's where it is, well, within a well-defined sheath. And then that sural nerve, very close to the vein, the further delayed as you go. This is going from distal to proximal and moves away from the vein. There are lots of variations with a small saphenous vein. 75% of the time it will join someplace into the deep system, but 25% of the time it'll cruise on up into the pelvis or well up into the thigh or buttocks. Small saphenous vein may join again the popliteal vein or the deep veins at a higher level. There may be no connection, which is quite common, and it's kind of important because some insurers will not pay for small saphenous ablation unless there is a sapheno-popliteal junction reflux. Well, if there isn't a sapheno-popliteal junction, as in 25% of the population, there can't possibly be a reflux through it, and they may not pay for it. The gastrocnemius veins may join the popliteal vein, the upper small, or the confluence at the SPJ. Soleal veins join the popliteal vein. Sapheno-popliteal junction, that's an image of it. Small saphenous vein coming down into the popliteal vein. This is a small, see if I can show you this, a small vein of Giacomini. That's it there, but it's not very clear. I think I have a better image, and that's obviously that large incompetent vein of Giacomini. This is the thigh extension down in the saphenous sheath, and here it is taking off from the small saphenous vein. Thigh extension, there's some variability. 70% of the time it will join the great saphenous vein, or up into the pelvis or buttocks, and much less frequent it's into the common femoral or the femoral vein itself. The clinical relevance of thigh extension, if it's incompetent, the patient may well have some posterior thigh pain and aching, especially when they're sitting like driving. It really does mimic a sciatica, but it's typically non-radiating. And it's often associated with reflux in the great saphenous vein and or the small saphenous vein. If you ablate then the truncal vein, you can salvage the small saphenous vein, or the intersaphenous may eliminate the saphenous, that small saphenous reflux. That is Sedona in northern Arizona, another spectacular place. A bit about perforators. Now, we used to have all sorts of names for these perforators, and thankfully that's going away. They're now anatomic names. The paratibial perforators used to be Dodds, and the Cockett perforators are now the upper, middle, and lower posterior tibial perforators. There's the medial gastroc and the lateral gastroc perforators and the lateral leg perforators, and the paratibial perforators and the lateral leg perforators. These do serve as a basis for venous drainage between the compartments, and they are not the enemy to fight. It's not uncommon to have an incompetent distal calf perforator because the great saphenous vein is delivering so much volume into the deep system through that perforator. It dilates the perforator and becomes incompetent. If you ablate the great saphenous vein, the incompetent great saphenous vein, that perforator will most likely become competent again. So it's not necessary to treat the perforator veins just because they're incompetent. A nice image perforator vein. These are all the thigh perforators, all the new names. And I won't go into those in detail. So as I said, they used to be the Hunterian were up in the thigh, the Dodds at distal thigh, Boyds just below the knee, and Cocketts. I think I said those were the Dodds before, but they're not. Those used to be Boyds and Cocketts. Now all of that's changed. It's become much simpler. That's an image of all of the veins that we talked about, but that at least now they are anatomic as opposed to just named. And I'll buzz through this pretty quickly. There can be long thigh perforators from the great saphenous vein into the femoral vein, and it's easy. If, for example, in this image, it'd be easy to put a wire, go down into the perforator into the femoral vein. That you really need to be careful about that sometimes, because it's not hard to do. That wire can slip on down there very easily, and it can be a real that obviously would be a real problem if you thermally ablated it. So watch out for that mistake. That's the Little Colorado River just before it enters the Colorado and the Grand Canyon. With the pelvic veins, you have all of these. Probably the most important are the ovarian vein, the testicular veins, the external and internal iliac veins, those rectal veins and the gluteal veins, and then all of these uterine veins, vaginal veins, pubic, deep circumflex iliacs. All of those are going to be important, and I've just kind of highlighted the most important ones. Of those rectal veins, for example, patients may present with hemorrhoidal disease, and it's just all part of the same process. This is the drainage showing that the left ovarian vein joins the renal vein, the right ovarian vein joins the iliac vein. This is the right common iliac and the left common iliac joining to become the IVC, and then down below the internal iliac and external iliac and the uterine venous plexus. That's important because if you see varicoses in that area, that's coming from something, and you need to have more testing to find out where that's coming from. This is that nest, and I'm going to show you an ultrasound image of it. There are lots of what they call pelvic escape points, the obturator, the gluteals. They all come out of the pelvis and down into the leg. And that's an typical ultrasound image of incompetent pelvic tributaries. If you do a power Doppler, you'll see this mess down in the pelvis, and you know that that's a pelvic venous insufficiency. And then this is an ultrasound image of an incompetent infragluteal vein coming down and joining the small saphenous vein there. Back to the Chiricahua National Monument. Just briefly about the lymphatics. Purpose is to return interstitial fluid from the periphery to the circulation. Now we know that virtually 100% of the fluid from the leg is going to return through that lymphatic system. There's both a deep and a superficial component, but the superficial in this case is much more important as opposed to the venous system, where the deep system is a more important drainage path. There's both proximal and distal. If it's proximal, I'll refer to a proximal, that's above the inguinal ligament. And if it's distal, it's below the inguinal ligament. They just like the veins, there can be aplasia and hypoplasia and hyperplasia, more than normal. We've traditionally done lymphangiography, but that's not done very much anymore. There are lots of, we were doing lymphoscintigraphy, but there's a bunch of other newer methods that are coming on board, that indocyanine green lymphography, and may be being replaced now by MR lymphangiography. And I just read a paper this week where ultrasound is used to delineate. So what you want with studies are to identify both anatomic and physiologic abnormalities on that lymph system, and all of these can help do that. There's both active and passive flow through the lymphatic system because there is peristalsis in the lymphangions, and passive flow from external compression or contraction of the muscles. And then most of these lymphatic vessels have valves. So we're now down to the conclusion. I want you to be aware of variable anatomy in the venous system and the lymphatic system for that matter, because if you don't know your venous anatomy, you never know what may be hiding from you. Thanks very much for your attention.
Thank you, Nick. As always, very thorough and organized discussion. Is there any questions for Dr. Morrison? So for the fellows, I would caution you that when you start preparing for your American Board and Venous and Lymphatic Medicine board examination, there are always at least 2 questions on embryology. So please, if you have a chance, these lectures are recorded. You may want to go back and review some of those things. There's always a question about the cardinal vein. There's always a question about duplicated inferior vena cavas and femoral veins and popliteal veins. There's usually a question about the thigh extensions and Giacomini veins as well. So this talk was full of test questions. So I would highly encourage all of you to go back and review this, especially when you're starting to prepare for your board examinations. So again, any questions from anybody?
Yes, Dr. Pelpas, I'm Mohammed. Quick question in regard to the first slides where it shows the pre-terminal and the terminal valves and the epigastric vein lying in between them. Now there is a couple of recommendation as far as placing the catheter, the RF catheter, 2 centimeters before the junction versus 2 centimeters before the superficial epigastric vein. And I was wondering which one is preferred, or both recommendation are right. And my question, Dr. Morrison, is since the reflux can happen from the epigastric vein, is it better to stop the catheter after the epigastric vein?
Most people do start the ablation below the entrance to the superficial epigastric vein. The problem is that it may be somewhat difficult to identify the superficial epigastric vein in the same plane as the saphenous vein, and so it's sometimes a little hard to be sure that you're below that junction. So they've adopted this 2 centimeter rule, which most of the time is correct, not always, but most of the time it's correct. I generally prefer to look at the superficial epigastric vein in that same plane, so I know for sure I'm below it. The sonographers are much better than I am at looking at a transverse image and not necessarily a longitudinal image to identify where they are.
Yeah, so Mohammed, I'd answer that question a little bit differently. When the radiofrequency catheters were first developed, they don't have the physical structure that they have now. They were a prong system, and the recommendation was 2 centimeters at that time. And several studies came out to show that 2 centimeters was fine, that there was a very low E-hit rate, except for one paper that came out of Brooklyn, which said that there was like a 7 to, I don't even remember, it's like almost a 15% E-hit rate.
Yeah, 16%.
Yeah, so that study by Enrico Asher and Emil Hingarani was found to be an outlier. So, because no other study has ever shown that before. But because of that study, the company at the time, which was Venous, recommended that you extend that 2 centimeters to 3 centimeters. So although I appreciate the fact that the Europeans are questioning that recommendation and that they're trying something else, that is not the standard of care in the United States right now. So the standard of care in the United States is at least 3 centimeters from the saphenofemoral junction. So you can go 2.5, but you probably be better safe by being 3 centimeters from the junction and away from the superficial epigastric. So there are people who strongly believe in preserving the superficial epigastric flow. And if you talk to Lowell Cabin, for example, he firmly believes that retrograde flow from the superficial epigastric is what prevents E-hits from forming or extensions. I don't know if it's true. There's no data to support that, but I do know that since pulling back the catheter to 3 centimeters, E-hit rates have dropped significantly. So if you're asking me what you should do 3 centimeters.
Thank you. That's
Same
thorough.
is true of adhesive ablation. You want to be 5 centimeters below because that adhesive will extend
Right.
up closer to the saphenofemoral junction. You really want to be well
Yeah,
below.
no, thank you for that clarification, Nick. So that 3 centimeter recommendation was just for laser, it's just for thermal ablations. Nick's absolutely right. For venous, you have to be at least 5 centimeters.
Thank you.
Any other questions? All right, thank you, Nick. Well, once again, excellent discussion. Everybody have a great weekend, and we'll talk soon.